Thank you so much for having me. It's really a pleasure to be here and talk about respiratory viruses. We're going to call this state of the art. Please feel free to ask questions. I've got the Q&A pulled up, and hopefully we can make this interactive. Um, we're going to talk a little bit about pandemics. We'll talk about some outpatient therapeutics, hopefully bread and butter questions that may come up for you in clinical care. We'll talk about avian flu, RSV, measles, and maybe a little bit about what the future may hold. So let's just talk about pandemics for a moment. This is a data visualization that uses data from Hopkins and CDC and the WHO. And you can see these are sort of representations of plagues throughout history. And you can see that many of these are, either plague itself, respiratory viruses, HIV, and then, of course, COVID-19 at the bottom here. Our current estimates through 2025 are that COVID-19 is probably directly related to about 7 million confirmed deaths, though, there's a lot of underreporting that happens there and many indirect deaths related to this. So when you take all of that into account, it's probably closer to 20 to 30 million to help put that in perspective for some of these other outbreaks. Now, I wanted to just play a little Family Feud, and I would love for people to just type into the Q&A if they have thoughts here. But I'm curious if you have any guesses, and of course there are no wrong answers, but what organisms are most likely to cause the next pandemic? And the answers that I've chosen here were taken from a survey of about 200 infectious disease docs that were based on some WHO work. A lot of them are based in the European Union. So I don't know. Oh, there we go. I see a few people typing in. Somebody suggested bird flu, somebody suggesting influenza, new strain of COVID, dengue. Completely agree with all of those. Feel free to type in any other answers if you'd like. But I agree at the very top of the list is influenza. And then, this feels like sort of cheating, but people call this disease X, which is something that maybe we just haven't seen before, a totally novel pathogen. Other things are different, strains of SARS, either COVID, maybe SARS-3 or the OG SARS. Then, of course, there's some of the hemorrhagic fevers, MERS, and Zika, I think, could represent a number of different arboviruses if climate conditions are right. And then other hemorrhagic fevers are on the list. So I think, regardless of whether it's the next pandemic or not, I think we're going to see a lot of these for the next 10, 20 years, unfortunately. Okay, so let's switch to outpatient COVID therapeutics, and we're going to start with a Zoom poll. So the first question is, this is a 50-year-old man with hypertension and obesity who presents with mild COVID-19 symptoms that began 3 days ago. He is not hospitalized, and he takes lisinopril and simvastatin daily. So which of the following is the most appropriate next step regarding Paxlovid therapy? Would it be A, prescribe Paxlovid without further review? B, prescribe Paxlovid after reviewing for drug interactions? C, do not prescribe Paxlovid because of age or comorbidities? Or D, do not prescribe Paxlovid because of symptom timing? So just take a moment and let me know what you think. It's tricky. I haven't been seeing a whole lot of COVID right now, but certainly at the end of the summer, I think a lot of people are saying B, and there's another smaller peak for D. So let's talk about that. I think B is probably the correct answer here, but I have some question marks around that we will explore. So Paxlovid, the generic name is just harder to say. It's a mouthful. So I'm going to mostly call it Paxlovid for this presentation, but it is the preferred therapy for symptomatic high-risk outpatients within 5 days. So just remember that symptomatic part of it is not for asymptomatic folks. We do dose adjust it for reduced GFRs. It has many drug interactions, as most of you know, so I almost always use a interaction checker online before prescribing this. And importantly, it has not been shown to improve time to symptom resolution, so really important to set expectations with patients. There's also the issue of rebound. And of course, we see rebound even without using Paxlovid. But the incidence is probably in the 10 to 15% range, hard to know. If somebody does rebound, we don't recommend retreatment. But What is the evidence behind our prescribing practice that is now ingrained, several years after the approval of Paxlovid? So part of this was based on something called the EPIC-HR or high risk study. This was authored by or sponsored by Pfizer, drafts written by consultants to Pfizer. These are people who had mild to moderate COVID. And if you cast your minds back to that dark time of December 2021, these were unvaccinated folks who were at high risk for progression and had this really impressive effect size of close to 90% for reducing death or hospitalization. And that's great, but that is one snapshot in time. And the question is, how is this relevant to our population of patients that we are treating today? So they actually finally published the EPIC-SR study, which is the standard risk study. Yes, it was published 2 years late. They held on to this data for much longer than anyone was anticipating. And these are fully vaxxed adults with one or more risk factors for progression, or they're folks who are unvaccinated without risk factors. There's a pretty broad age range overall. This is a population that was at relatively high risk for progression. And in this standard risk population, there was no benefit to symptom reduction and no benefit to hospitalization or death. So very, very different effect size than we saw with the prior RCT in high-risk patients. Now, what about more recent data? This is a very, very interesting study that was just published this year as a research letter in JAMA. And this is a natural experiment. Ontario has an age-restrictive prescription policy, so you can get Paxlovid if you're over 70, but you can't get it below 70. And so the question is, did it show a difference on either side of that split? So they could actually look at well over 1 million Ontarians, and they saw that there was no significant reduction in COVID hospitalization, all-cause hospitalization, or mortality, and there was a 4 times smaller effect size than the original trial results in unvaccinated folks. And so again, the conclusion here, which is concordant with that standard risk study, is that Paxlovid may not significantly reduce hospitalizations and mortality in heavily vaccinated older adults. And so I think the question in my mind is this kind of the death knell for Paxlovid in non-immunocompromised patients? My personal take is probably. I do think it is very difficult to stop prescribing practices once they've been normalized. And can't, also Tamiflu is a good example of this, which was prescribed in 99 without great data behind it. But anyway, I will throw that out as a rhetorical question. There's also molnupiravir in our arsenal. And of course, there's conflicting expert opinions on whether to continue to use this. This does in vitro inhibit SARS-CoV-2 replication. It is still under EUA. It has not been formally approved by the FDA, and it is for symptomatic patients within 5 days, so very similar indication for Paxlovid. It's contraindicated in folks under 18 in pregnancy, and it's primarily because there's this very concerning, it's hard to know how widespread it is, but for me, it is very hard to counsel patients around this idea that we could be contributing to mutagenesis by prescribing this medication. And men actually need to use contraception for 3 months following therapy because of this concern. The largest randomized controlled trial that looked at the efficacy of molnupiravir was called the Panoramic trial, and it showed no statistical benefit in decreasing hospitalization or death. It was an open-label trial, and there's a 4-day improvement in symptoms. So could we be seeing some placebo benefit in this open-label trial design? Hard to say. We have not seen that same effect in other trials. So I am very hesitant about prescribing molnupiravir. And then, of course, there's remdesivir, which is approved for high-risk symptomatic folks. We use it. I think the benefit in vaccinated or previously infected folks is really not clear. And then, of course, there's really just this burden on health systems and the amount of health system resources it takes to administer 3 days worth of this medication. So we're just not seeing a whole lot of use. There is an oral version that is in trials and looks like it may be non-inferior, but more to come on that. And then I think the monoclonal space is shrinking by the year. It just takes a lot of R&D to bring these things to market, particularly because of the cost and resistance. They're normally short-lived. They're dosed every 3 months. So we do it occasionally for our highest risk patients, but I am really not sure what the role is going to be in the next few years for monoclonals. So just switching gears to the vaccination side, how well do boosters protect against Omicron? Well, these are estimates from the monovalent boosters from 2024 and 2025 from the Nature study. These are, at the time, this is the circulating Omicron descendant variant. This is a VA cohort with a test negative design, a median age of about 68 years. Most of the vets were over 65 years old, and the vaccine efficacy was about 68% against hospitalization, which is pretty great for a respiratory vaccine. Had a 57% effect against ED visits or urgent care visits. And then, of course, unfortunately, the vaccine uptake was quite low. So I think we're underusing a vaccine that probably has significant benefits in this population. And then the other question that patients may ask you in your clinic is, doc, when should I actually get boosted? Is there an ideal time? So this is a modeling study that really takes into account some geographic variation and infection, and including, climate data. And I think, we've seen that boosters really can provide probably 3 to 5 times more protection than people would get just from natural immunity. And the conclusion here is that probably early autumn in the Northern Hemisphere, so a month ago or even now is a great time to get boosted. And if they have a breakthrough infection, they can often delay. I typically delay by about 3 months and then get the booster after that. Okay, so next question is, what is the future of mRNA vaccines for respiratory viruses? And the reason I bring this up is, sadly, we don't actually know what the future is, because about $500 million in mRNA research was just slashed. A lot of it is, unfortunately, false claims against vaccine safety and effectiveness. So many grants were cut, but there are still some bright signals out there for what mRNA vaccines are capable of. I did want to share this very cool paper with you. You may have heard about it on the news. It was actually on a local news station that I was listening to recently. And this is the idea that mRNA vaccines actually have these off-target effects and can sensitize tumors to immune checkpoint inhibitors. So this is the authors sort of framed it as the mRNA vaccines are reprogramming this microtumor environment. And so this is followed up by a large MD Anderson cohort where patients with non-small cell lung cancer, metastatic melanoma, were actually found to have markedly longer survival if they were vaxxed within 100 days of starting immunotherapy. And I would say, of course, there are a lot of caveats here. I think confounding is certainly possible, but if you look at this paper, they really go into some detail about possible mechanisms here, which I think are very compelling. So very, very interesting what may happen with the field of mRNA vaccines in the future. I'm going to switch gears here and talk a little bit about seasonal influenza. So we'll do another case. This is a 34-year-old woman who presents to clinic with 36 hours of fever, myalgia, sore throat, and cough. She is otherwise healthy. She takes no medications and has no chronic medical conditions, and her rapid flu test is positive. So the question here is, which of the following is the most appropriate next step regarding antiviral therapy? Is it A, start oseltamivir for 5 days? B, start oseltamivir for 10 days? C, start oral baloxavir? Or E, no antiviral therapy is required, supportive care alone is reasonable. So let me know what you think. Again, haven't seen a ton of flu cases yet, but I think, activity is starting to pick up in other parts of the United States and will slowly make its way here to Washington. Okay, great. So I see really the majority of people saying E, no antiviral therapy is required. And I think that's where I would come down on this. I think, by recommendation, some people would also, I think it's defensible to say start oral oseltamivir for 5 days. But I would just say, in general, for otherwise healthy, non-hospitalized adults, uncomplicated influenza, also Tamiflu for 5 days, you can, but supportive care would be very reasonable. And of course, antiviral therapy is most beneficial if it's started within 48 hours of symptom onset. So how did the flu shots look last year? These were preliminary estimates from several US vaccine networks. And we saw that among children and adolescents, the efficacy was about 63 to 78% against flu-related hospitalization, which is pretty good. And adults kind of came down around coin flip, 50-50 against flu-associated hospitalization. Those are very similar to our neighbors to the north who do similar studies on this. But the conclusion here is, vaccination clearly reduced the risk for influenza-associated outpatient visits and hospitalizations, which is terrific. And even, in years when H3N2 predominates, it's typically a worse match. The vaccines are just not as effective against it and still held up, pretty well. This is just how our flu vaccine effectiveness looks. Effectiveness, of course, means real world efficacy. Efficacy is in randomized control trials. So we can see that last year did pretty well, over 50%, which is a little bit better than where we typically stand for vaccine efficacy. Okay. All right. I see a question in the chat here. How effective is this year's influenza vaccine given lack of ability? Yeah. So we don't know yet. It's a great question about this year's vaccine efficacy. The vaccines performed very well in the Southern Hemisphere, and so we're optimistic that it will probably do pretty well here unless there's some significant antigenic drift or shift that moves the strains away from where we're predicting. So just in case you need another reason to get a flu shot, this is a meta-analysis looking at MI, cardiovascular death and stroke in patients who got the flu vaccine. And we saw that people who got vaccinated had a decrease in major cardiovascular events. So you can see there's a 30% reduction here, decrease in risk of MI, and significant reduction in cardiovascular death. So, just in case you need yet another way to counsel folks who may be on the fence about getting their flu shot, it's a great adjunct to preventing cardiovascular disease in addition to preventing the flu. Okay. And what about mRNA vaccines? Well, I do think they're promising. The benefit is this is a much more nimble and flexible platform. And of course, you've got the shorter manufacturing time. So, the person in the chat who was asking about, how good are our vaccines for this coming year? These strains get picked like 6 months in advance. And so currently, if we pick the wrong strain or it mutates, there's going to be a bad match. But with mRNA vaccines, you can adjust it much more quickly. They tend to have broader, more durable protection. There are several that are in phase 3 trials, including a combo flu and COVID vaccine. So I'm very excited to see these. I don't know how the funding cuts are going to impact these. Of course, a lot of these are manufacturer driven at this point. And I don't know what the uptake is going to be, but I do think it's potentially going to be a solid tool for public health. And importantly, they did not see any major safety concerns. Okay, so what about also Tamiflu? I think this is a clinical conundrum that comes up for me every winter. Its impact on hospitalization is really unclear, particularly in higher risk patients. And we have conflicting meta-analyses to contend with. So in general, there's a 2024 meta-analysis that showed no benefit to hospitalization, including people over the age of 65. And of course, these hospitalization rates were quite low. And then a 2015 meta-analysis that showed a shorter time to symptom resolution and maybe slight improvement in hospitalization. So again, slightly conflicting findings. Effect sizes are very, very small. I think we probably are not going to have a great answer for how good also Tamiflu is, though I remain skeptical that it is doing much for most of our patients. Baloxavir is a second-line agent for influenza. It is currently approved for illness or flu illness that lasts under 48 hours. It is given as a single dose. The advantages are that it's better tolerated from a GI perspective than oseltamivir, and it may, see those quotes around may shorten symptoms by a day or so. The challenge is, we see resistance to also baloxavir emerge after a single dose. And so that really limits the long-term utility of baloxavir therapy and really limits its ability to be used in immunocompromised patients because these folks can shed influenza for quite some time and develop pretty rapid resistance to baloxavir. If you kind of squint at this graph here from the baloxavir study, you can see the proportion of patients without improvement on the y-axis, and then the baloxavir line in red and the oseltamivir line in blue. And you can see that the baloxavir and oseltamivir, those lines kind of hug each other pretty quickly and don't really diverge, although the placebo line does diverge. So I would say they performed relatively similarly. There's a question in the chat about does oseltamivir prevent flu after exposure, and it does. And so that would be the indication for prescribing oseltamivir once daily for 10 days. And it tends to be pretty effective for that. So for somebody who really has a high risk exposure, you could certainly consider giving it once daily, and it tends to be pretty well tolerated. There's another question about what is the duration of reduction of MI after flu vaccination. That's a great question. And I don't actually know the duration of that. I imagine, the vaccine probably lasts for 6 months or so, and I imagine that's probably a similar, reduction of all these other, adjunctive benefits as well. But I don't know if anybody knows the answer to that. Okay, so I know it's later in the afternoon. I encourage you to just, stand up and stretch for a minute. I have one kind of brain break that's planned that hopefully you will find interesting, and then let you focus on the second half of the talk. But I have one more Zoom poll for you here. And the question is, to your knowledge, has there ever been a pandemic due to a lab leak that's been supported by strong evidence? And I want you to either vote A, yes, or B, no. So you could just launch a Zoom poll and let me know what you think about, has there been a pandemic caused by a lab leak that's been supported by strong evidence? Let me know what you think. Okay, so a lot of people are saying no, and about 17% are saying yes. So I love it. So let's dive into this. So it actually is yes, but probably not the one that you're thinking of. So there actually was a lab leak flu. This was a 1977 H1N1 outbreak. And the story is this was a flu that actually rapidly appeared in northern China in the Soviet Union and then became endemic globally very quickly. This was a strain that had not been seen since 1957. And what's interesting about it is if it was naturally occurring, we would have expected to see some antigenic drift since 1957, but actually it was genetically identical without any changes in its genome since the 50s. And so it's strongly suspected that this is probably related to a vaccine trial or a lab experiment and was inadvertently released into the wild. No country ever publicly acknowledged responsibility, but it is the only known cause of a lab leak pandemic supported by strong evidence that I'm aware of. I'm not getting into COVID origins here, but this is just a fascinating anecdote in history that these things do happen. Okay. So let's switch gears and talk about avian flu, something that keeps me up at night. I think that the challenge with pandemic flu is it is impossible to predict and comes at these irregular intervals. So, I think we're all familiar with the 1918 H1N1 pandemic, upwards of 50 million deaths. Interestingly, it's the only flu pandemic that was caused by wild bird to human transmission. There's, a 1957 pandemic, 68, 2009, and then of course there's some smaller ones along the way. And then afterwards, after these are pandemics, they become endemic, which is why we're still dealing with seasonal H1N1 now. And I really like this quote from the Science article from a few years ago that just really emphasizes how humbling it is that despite many recent advances in public health, surveillance, virology, we are a little better at predicting pandemic emergences than we were before 1918. So with avian flu, it's a whole alphabet soup that you may have heard of. But what really gets people's ears perked up is we start to see these large die-offs of migratory birds and mammals over the last few years, which is very suggestive of mammal-to-mammal transmission. And then you see these kind of handful of cases here and there of single human cases, across the globe since 2021. We haven't seen any sustained human-to-human transmission thus far. Then we start to hear about this H5N1 outbreak. And so this is a virus that descended from China in kind of 96, 97. And 97 led to 18 human infections and 6 deaths. And that's part of why we initially saw these really high estimates for case fatality rates that came from that outbreak. And this strain really stayed in Asia until 2021, and then just had this explosive spread in poultry farms here in the United States the following year. We've basically had to slaughter, hundreds of millions of birds since 2022 because of this. And I think the challenge with avian flu is one of coordination. It's really sort of it's this idea of a paradigm of, you really need a coordinated One Health response, and it has been very hard to get coordination among these sectors. And one of those components, of course, is vaccines for animals. And the US historically has been very hesitant to deploy poultry vaccination, partly because, meat producers in particular really fear for export losses if vaccinated poultry are, restricted on international markets. And, farmers may or may not be reimbursed who have to cull their flocks. Egg producers, on the other hand, tend to favor it because it helps with egg production. And then there's the question of what about flu in cows, right? Because that's a parallel outbreak that we're seeing. And we started to see that in 2024 when vets along the Texas Panhandle started describing the syndrome of infecting dairy cows, where they see this drop in milk production. This milk was clearly abnormal. It peaked at about a week or so and then got better. And we start to see the USDA announce these outbreaks alongside deaths of birds and cats. Interestingly, in these papers, you may remember that cats who contracted it had about a 50% mortality rate on these farms. A lot of this transmission is probably related to milking machines and other implements of industrial era farm equipment. And then we see it in the milk supply. So about close to 60% of milk samples from 10 states were PCR positive for avian flu. We see it in the wastewater. I would say, I realize that wellness has never been more popular or lucrative. And I think this 4.4 estimate is certainly an underestimate in Seattle and probably Vashon Island. But I would just say beware of raw dairy and pasteurization works. It gets rid of avian flu and all sorts of other things. But the challenge with flu in cows is, this is now something that is mammalian adapted. And so this is a new interface for humans and animals. And anytime you have that, there is a potential for pandemics. So what about avian flu in humans? The highest risk are probably dairy workers. They're, exposed to all sorts of spills, sprays, aerosols. This plays out across, thousands of human-animal interactions across hundreds of thousands of farms, every day. And we just have very limited surveillance and testing for this. The majority of cases so far have occurred in farm workers. These are folks who are generally healthy. You can see these ocular symptoms. That's probably related to the mode of inoculation. But we have had 2 deaths in North America. There's a teenager in British Columbia, and then sort of middle-aged or older person in Louisiana, and then other people who have described severe infections, including people who keep backyard flocks. I would say the best estimate for case fatality in humans right now is probably closer to 2%, but we are still learning more about this disease, particularly as it continues to evolve. And I think the unanswered questions are really, how acute is the pandemic risk? How big is the outbreak? How common is the clinical infection? How is it spread? What is the risk to pigs? Because of course, those are the great mixing vessels, and have the potential for other to create additional pandemics. So I think we don't know the answers to these questions, and we're really not doing enough testing. I'm going to just skip through this human vaccines part of it, but I would just say we clearly need better and newer platforms for both seasonal flu and avian flu that are more nimble to respond. So just take home points here for avian flu. We really need this One Health approach. Biosecurity and surveillance in the poultry sector are really the frontline defenses, and I'm worried that that those are quite porous right now. Human cases of H5N1 currently have been, they are mild in some cases, severe in others. There thankfully has been no sustained human transmission. But you may see it this year where people come into the clinic with avian flu, and it's great to take a detailed history about that. Okay, I'm going to switch gears just in the last few minutes here and talk about RSV, and then we'll get on to one other topic. So this is a very frequent cause of hospitalization in U.S. infants, and of course, leading cause of pneumonia worldwide, and causes severe lower respiratory infections in frail older adults. And the challenge was we just did not have great vaccines previously, and all of a sudden we have this abundance of these incredible vaccines based on the RSV fusion glycoprotein. And so this is really a breakthrough that was 60 years in the making. And this is a study that I just wanted to highlight. So how long does immunity last? We've seen that single dose vaccines for people over 60 is effective for probably 3 seasons at about a 63% cumulative efficacy. So pretty good. Still wanes over time, as vaccines will for respiratory viruses. We did not see a benefit to a booster dose after a year. And so currently there's no recommendation for a booster dose, and importantly, there's no safety signal. So the current recommendations are, that anybody over the age of 65 should get a single dose of an RSV vaccine. People who are 50 to 74 and at increased risk should get a dose. And then there are separate recommendations for pregnant people and babies, and I encourage you to check out the CDC website, which is still up to date and accurate for those populations. Okay, this is I think our last topic, which is what childhood vaccine has saved the most lives in the last 50 years. Feel free to type it into the Q&A if you think you know. But I think most of you are probably thinking the same thing, which is measles. So that's exactly right, and it's not even close. Measles has far and away saved the most lives of any vaccine, and you may know that measles was considered eliminated in the U.S. in 2000 due to lack of endemic cases. But of course, we are currently at risk of losing that elimination status, which is defined by the WHO, which of course we are also no longer part of. And of course, these are weekly cases of measles currently, and this trend is something that we should all take very, very seriously, especially as vaccination coverage across the U.S. is decreasing. The clinical case definition is fever, rash, cough, cries, or conjunctivitis, and I think any of you may see a case this year. I think we are all waiting for additional cases across Washington. Frequently, there is a known epi-link. I would say, obviously, most people who show up with a rash in the ED or elsewhere do not need to be ruled out for measles. It is good to take a history and see if they have a known contact to somebody else who may have a rash or measles. And about 2 to 3 per thousand cases will develop encephalitis or death. A really important, but I think underappreciated feature of measles is this idea of immune amnesia. The idea that measles resets your immune system. There's this immune-mediated destruction of memory T cells and B cells. And so people across the world who recover from measles have this increased vulnerability to all other pathogens that likely last 2 to 3 years following infection. And so many childhood deaths that are related to other infections can actually be traced back to immune amnesia that's induced by measles, which is a really fascinating property. The US outbreak is huge and is growing and is markedly, the cases are markedly up since 2024. And, over 40, separate outbreaks in 2025. Almost all of these are, in communities that are under-vaccinated with low vaccination rates. We've seen at least 3 deaths and multiple hospitalizations this year. And I would just say this 2025 in particular is really a pivotal year for US measles control. This vaccine saves the lives of 2 to 3 million people globally. It is highly effective. And just to be very clear, and you can say this definitively to your patients, there's no link to autism or any other conditions, including diabetes, developmental delay, et cetera. There are very few contraindications, so it's a live vaccine. So be careful if people are immunocompromised and people who are pregnant. Otherwise, people do just fine. I would say, I think that the timely question that comes up is who needs a booster? And I've summarized, there's a review in the New England Journal that is excellent that was published this year. So please feel free to go to that as a reference. But I would just summarize it as, most people, it's not routinely indicated. Some people could benefit from a second dose if they only received 1 dose between 67 and 89. That's especially true if you're a healthcare worker or an international traveler. And then for a small period of time, there are people who had an inactivated vaccine between 63 and 67. And so you can consider an extra dose for that. Okay, so my last slide here is what will future waves look like? And I think, my sincere hope is that hopefully explosive waves are behind us for COVID. Of course, that bars some new Omicron-like event, which, could happen at some point in the next 10 or 20 years, but hopefully it's not, statistically highly probable. So we're in this wavelet era where we're seeing these smaller waves multiple times a year, thankfully lower impact on hospitalizations, but it's important to know that this has less seasonality for flu, and that's, important to think about as, we are counseling our patients around vaccines and when to get vaccines. And it's just, COVID inherently has this higher mutation rate and just shorter-lived immunity compared to flu. So for now, we're going to see this continued circulation with new variants for the time being. So my take-home points here are better therapeutics are needed for respiratory viruses. Many pathogens pose a pandemic risk, with avian flu being at the top of the list. We really need a One Health approach. I'd say we're really underprepared for another pandemic. It pains me to say that. RSV vaccines are a huge breakthrough, and we really need some improved flu vaccines that I think are probably on the horizon. It's something that I'm really excited about. So with that, I'm going to stop. Thank you so much for listening toward the end of the day, and I'm happy to take any questions.
Great. Thank you so much, Dr. Cohen. I did see one question in the chat that I wanted to read. I was recently looking at immunization rates on the new Department of Health respiratory database and was surprised by the low rates. How do you recommend advocating for vaccines, especially in our current climate, and how vaccines have become so politicized?
Yeah, I mean, that is thank you, Judy, for that question. And that is just a hard one to unpack. You're right, they are shockingly low. I do think, there are many societies, including ACP, who have done terrific advocacy work. And I really think that's where we, as physicians, can really make a difference. And I think, I think there is still a lot of trust in physicians. I think on social media, in, writing op-eds is easier than, many people think. And there are all sorts of opportunities to get engaged. So I feel like although it's easy to become cynical, I have really felt that, we can really make our voices heard. So that's my brief, optimistic pep talk on that, but it is a thorny issue for sure.
Great. It looks like one more. How often would you recommend getting COVID boosters given there's no seasonality, once per year or every 6 months?
I think it depends on the patient a little bit. I would say, for people who are generally healthy or healthcare workers, for example, I plan to get mine probably once a year. But I think for people who really have, more who are higher risk, either because of age or significant medical conditions, I think twice yearly is very reasonable given what we know about waning antibodies and the fact that we do see these summer surges predictably.
All right. Well, thank you so much for a fantastic last plenary of our day.